Good afternoon. My name is Russell, and in this video presentation, I will be discussing the scapula. This will be routine and trauma techniques, positions, body position, the path of descent array, immobilization devices, anatomy, technical factors, and 2 clinical indications. Anatomy of the scapula. I would like to discuss the anterior aspect of the scapula first. This is the right scapula. Starting off with the acromion, we will move on to the coracoid, glenoid cavity, lateral border, inferior angle, medial border. The entire surface here is known as the subscapular fossa, superior angle, superior border, and the suprascapular notch. Next, moving on to the posterior aspect here. This is the right scapula as well. We have the superior angle, the supraspinous fossa, the spine, the infraspinous fossa, the medial border, the lateral border, the glenoid cavity, the acromion, the coracoid process, and the suprascapular notch. Here are a few techniques and devices used to immobilize the scapula in order to prevent further injury. So we would have a sling or shoulder immobilizer. A sling is a basic arm rest that you would place your forearm and elbow in to prevent any movement laterally or anteriorly. And an immobilizer will prevent all movement regarding the arm and keeping the scapula in a neutral position. Clinical indications would basically be a person coming in with pain in their shoulder or upper back near the scapular region. A few different pathologies seen on x-rays would be the acromioclavicular joint dislocation, and this would be the distal clavicle would be displaced superiorly, best seen on a bilateral erect AC joint x-ray. You would also have acromioclavicular joint separation, which is partial or complete tear of the acromioclavicular joint without weights, and this would be to rule out fractures, and this is also best seen on a bilateral erect acromioclavicular joint x-ray. Another clinical indication and x-ray you would see common injuries of the scapula would be a Bankart lesion, and this would be an injury or pain radiating from the level of axilla. A Bankart lesion is an injury to the anterior inferior aspect of the glenoid labrum. Repeated dislocation causes a small avulsion fracture of the anterior glenoid rim, and to view this would be best seen on a Gracie positioned x-ray. Next, I'm going to talk about positioning routine, also trauma routine, and the positioning of the patient. Here in this image, we have an AP view of the scapula. This will demonstrate the entire scapula. The CR would be perpendicular to the mid-scapula 2 inches inferior to the coracoid process, and 2 inches medially from the lateral border of the patient. You will ask the patient to abduct the arm 90 degrees, and if possible, supinate the hand. Center the IR to the entire scapula. Next would be the Gracie method, and in this method, I would use a technique of 75 kV and 5 MAS. This will open up the scapulohumeral joint space. In this position, you would place the center ray perpendicular to the scapulohumeral joint and oblique the patient 35 to 45 degrees towards the IR with site of interest against the IR. Hand and arm placed in a neutral rotation. Center the mid-scapulohumeral joint to the CR. This would be 2 inches inferior and medial from the superior-lateral border of the shoulder. Next position is the scapular Y, but this one is for trauma. The technique I would use is about 80 kV and 10 MAS. This is to view the scapular Y. In this image, it would give you a true lateral view of the scapula. The projection is PA. You would rotate the affected shoulder into a 45 to 60 degree posterior oblique as for a lateral scapula. The unaffected arm would be in front of the patient and the affected arm side would be down. Next, I want to talk about the lateral view of the scapula. In this view, we will use about 80 kV and 10 MAS. For this view, you would see the entire scapula demonstrated in a lateral position. The center ray would be perpendicular to the mid-vertebral border of the scapula. You would palpate the patient's border of the scapula and rotate their thorax until the scapula is perpendicular to the IR. Finally, I want to talk about the last position, which is involving the scapula, but is technically not a scapular view, and this would be the AC joints. Seeing how it has the acromion, I will include this in my report. The AC joint, I would use a technique of about 80 kV and 5 MAS, and this is to view the right and left AC joints and also SC joints included. The center ray would be perpendicular to the midpoint of the AC joints. 1 inch above the jugular notch. Arms at the side on one exposure for bilateral without weights and one exposure with weights after ruling out fractures.